we're going to move into a space that is much more comfortable to me, as my panelists here know, which is the world of policy, working with the federal government, working with states, and really try and bring some context. As you heard, can't ignore policy. If you ever could, you certainly can't do it now. And you've heard that throughout the last day and change here. And so we're going to really get specific about the unprecedented scale of these policy shifts under H.R.1, how states are actually going to be navigating these budget pressures and what that means for the delivery system, because that's of course going to, and that already has directly affected the delivery system. And then really some practical ways to engage with states and support these initiatives. And you'll see that my panel is uniquely qualified to help answer those questions. So I have Jacey Cooper, who was a former California Medicaid Director, among many other things, and Kody Kinsley, who was formerly the Secretary of Health and Human Services for the state of North Carolina. So they are both really well positioned to sort of answer this and help us provide some context here. So I very briefly introed you. Say other words about your experience and what you've been doing.
Sure. So I, 20 years in Medicaid. The way I split it is the first decade was in public hospitals. So running indigent care programs, inpatient, outpatient, various areas. And so grounded myself in the delivery system and those various reforms, including behavioral health integration early. And the second decade was in government, state government for 8 years, and the federal government for almost 2. And so both of those bring a good lens of both policy and implementation.
Yeah, and Kody.
I spent about 15 years in government, split between the federal government and state. Most of my federal time was actually at the U.S. Treasury, where I served as the CFO, COO under President Obama and held over under President Trump, the only political appointee to serve in both administrations. And then in North Carolina, just wrapped up my tenure as HHS Secretary in the best state in the country.
Wow.
Sorry, Jason.
Those are bold. Those are really bold
There's
words.
a mountain lion
There's
in the streets of San Francisco. I was like, this is my note to get out. Goodbye. Give me bears any day.
And ice storms, so you can have them. So we have a lot to cover in a very short time. Like I said, we want to talk about the magnitude of change with H.R.1, which I realize, understatement, right, for sure. We want to talk about a really important federal-state dynamic shift, which we'll get into more details on. That's really important to understand the broader picture here. We want to talk about what you've heard probably, the Rural Health Transformation Fund, what it actually is, what it means, what it isn't, and then really some opportunities for, again, how the delivery system can respond. So let's start with sort of, as former state executives, what is keeping your colleagues who are still in state service up right now at night? Why can't they sleep beyond the mountain lion at their door?
So H.R.1 was, in my opinion, the largest policy change in healthcare in the last 15 years. I mean, it added up to $1 trillion taken out of the health system in the next 10 years. And with that, operationalizing that is going to be immensely challenging. And there's an aggressive timeline. And so what's keeping state health secretaries and Medicaid directors up is the anticipation of needing to do a whole lot of work to implement these changes without a lot of guidance. And it's an aggressive timeline. We've seen what happens when tech projects move quickly in government. Sometimes they don't work well. And in the midst of all that, there's a whole lot of other changes happening as well in healthcare. So it's a time when there's a lot happening and states are just trying to keep up. That's what's keeping them up at night.
Yeah, I mean, I think it's also the double hit of coverage and financing. They took a lot of the tools out of the toolbox that states use. When you have economic downturns, Medicaid agencies use things like provider taxes to cover losses. Well, those are gone, right? So not only is it a substantial change, they're changing in regards to how the program's financed, which gives states less options. And the other thing is, with the target on expansion states, you have states that have been talking about, the insured numbers in their states have been huge for a long time. And you're now going to go back a decade or plus, to your point, in regards to understanding uncompensated care pool, how to have a healthcare delivery system to meet the needs of uninsured people. It's a shift that is substantial, and all priorities states had before H.R.1 just went out the window, because they're 100% going to be focused on late regs coming out from CMS, struggling to implement those in timelines that are unrealistic. It will take up all of their capacity and time.
Yeah. What does, like we were talking about the cut, what it means for each state, what does a $30 billion cut for a state like California actually mean in practice?
Yeah, I mean, it's huge. So California is estimating $30 billion annually, for the record, not over the 10-year, $30 billion annual cut, and 3.4 million potential lost coverage. There's 20 states in the US who don't even have 3.4 million residents in their entire state, right? So the impact is substantial. And states only really have kind of three main levers in their back pocket. They can cut rates, they can cut coverage, and they can cut benefits that are being offered. The other is if they have a lot of state-only programs, they can cut those. So that's what California is going to have to do. They're going to have to significantly scale back on their coverage of undocumented or UIS population. And then there will be real cuts in states that are going to be impacted that hard. Just to give a little bit of context, all cuts in H.R.1 are not equal. And what I mean by that is if you lose coverage, you're not putting up the general fund and then you lose the federal fund. The real cuts are when they're reducing the federal match or provider taxes, where you're putting in very little of state general fund. In order to keep the things that were funding those things, you actually have to find general fund to replace them, or they go away. And so those are the things that states are going to have to really work with.
Yeah.
Another significant change in H.R.1 is that for expansion states, individuals on expanded Medicaid will now have to get redetermined every 6 months instead of annually. And so we're going to see a significant amount of churn. I think for the folks here in this room, that's even more uncertainty as people walk in the door. What's their coverage status? Helping them navigate what that looks like. For the conversations that have been happening around population health, you have significantly less tools in your toolbox to try to help move people, as a former panelist said, to the left, if you're not sure if they're going to have coverage in just a few months or weeks. Mm-hmm. There's significant work in moving people through eligibility. That's a hard process. And so, we're going to have to see that unfold too.
Yeah. And Jacey, one of your other roles that we didn't talk about was working also at CMMI on, I think, the state demonstrations group. So really understanding as well from the federal perspective how you then write policy and design programs to work with states, which has been a long-standing challenge. I think when they wrote the statute for CMMI, it was called CMI, and then they were like, oh, we should probably add Medicaid. And it's been a challenge ever since to figure out exactly how to bring those transformation programs to the states and really engage deeply. And later, preview, shortly here on the stage, we'll talk more about some of those new models and how they're trying to also engage with states. But we talked a little bit when we were prepping for this about there's a fundamental change in the way that CMS is managing or thinking about Medicaid and Medicaid policy. Can you talk more about that and what that change means?
Yeah, and just a slight tweak, I was at CMCS
oh, I'm sorry.
over the 1115 demonstrations, but still the same Medicaid pieces. Yes. I mean, I think it is a fundamental shift how CMS, and I say this in a lot of times when I'm talking about H.R.1, this is the first time CMS is really managing Medicaid, for lack of a better description. They have managed Medicare for a long time very closely. Medicaid is now the largest M, for the record. 77 million lives in Medicaid, 69 million in Medicare, and around low 20s, sorry, I don't know the marketplace number right now because it's changing too much. They're the biggest M. When your costs are growing that much, they're going to start managing it. I think this will be a new trend in regards to how administrations focus on Medicaid more. So I think that is a real thing. And so states have to think a little differently too. States are going to have to think about how do you stabilize for sustainability in the future? How do you have a base that is stable from both a coverage and a benefit point of view? How do you know where you take risks and where you don't take risks? And those are decisions states always make, but in this environment now, it will be a whole different ballgame. It is a game changer in regards to how CMS is thinking and the things they're doing. They're no longer just writing regs to set the boundaries of what states can do in a state-federal partnership. They're completely changing the game in regards to what they think their role is in regards to managing Medicaid, like they've done on the Medicare side from the beginning. So it's a new shift, and I think once you've done it once, it will now be in the playbook. It will be there for people to use, and so you have to think a little bit differently as a state, strategically, where you're going to put risk, both financially, operationally, and really put some time into building those for the future, because providers need predictability. The system needs somewhat of predictability to be able to get through this.
Yeah.
And beyond coverage, I think thinking about what benefits are actually covered. For the last, it probably won't surprise anybody in this room, but when you invest in social care, food, transportation, housing, we tend to see utilization of emergency departments go down. North Carolina had its Healthy Opportunities pilots. We bore out through that a savings of $85 per member per month when we invest in those sorts of social care things. California has a similar effort that they've done. I've negotiated with Jacey. She's very tough when we were going through our 1115 waiver process to try to cover those things. And the administration is really shifting its stance on that policy. I will say we negotiated our 1115 initially with the Trump administration in his first term, and we were bullish about that with Seema Verma and had a lot of positive outcome from that. And there's been an effort to maybe dial that back, and I think we're seeing that policy still settle, but that's that more uncertainty. And so when we're thinking about what can Medicaid cover in the prevention space, still a lot of uncertainty there as well.
Well, I think you make an important point as well, which is that, okay, we had this pilot, we had a waiver, that was something that you were doing at CMCS, and then there were states like North Carolina negotiating there. You had the rules out there, you defined what it was, you defined what success looked like, and you started to show success, and it doesn't matter, it's gone. Of course it's not gone, there was important work that happened, and there's important evidence that was generated through that, but those things take longer than one political cycle to prove out. We've talked a little bit at the conference so far about how some of these new models and new initiatives are now sort of scheduled for 10 years, which we think is generally positive. But we know that it takes, longer than, again, one political cycle, 2 years before the midterms, whatever it is, to show these kind of outcomes. And then what do you do now? So, you're not in that role anymore, but your colleagues, okay, that's been canceled, huge amount of money that was there to fund a program. What do you do when every dollar is spoken for, but you know that you can reduce those, emergency room visits, avoidable emergency room visits, you can improve health outcomes. What do you do now with a shrinking budget?
Well, I think it makes conversations like this one even more important, right? I think everybody in this room, or I hope everybody in this room, would agree on the value proposition of shifting things to the left. I mean, I've heard these conversations happening, and there's a lot of dollars in this system. I think it takes more collaborative, multi-payer strategies. How do we bring people together into alignment? And I don't want to, I think we're going to segue here in a moment to talking more about the Rural Health Transformation Program and some of the other data sharing strategies. I think later today, Amy Gleason will be on the stage. And so I think that there's some good things happening in focusing what can do and come out of this administration, and the focus is just a very different approach. And as Lisa was sharing, these are big ships, right? 77 million people. Like, turning these on a dime are not easy, and they're not easy for our providers who are trying to set strategies and make investments over decades. And so we're seeing a really major shift. We've turned hard to one side, and I think that there's still a lot of adaptability happening in states. It's just going to look different. It may not be through the 1115 waiver. It may look more of like in lieu of services. It may look more like kind of contractual agreements with multi-payers. It's going to see maybe drafting off some of the initiatives in the Rural Health Transformation Program to focus in more on value-based payment and what that looks like, all of which will require immense enablement through better tech, data, AI, and trying to understand what is actually turns out, maybe to close that cycle on the evaluation point, right? Like a 10-year model sounds great based off the old kind of way of doing things. We probably have to close that cycle time to make it faster. And so I think, there is some positive destruction happening, but it's going to be painful.
Yeah. So let's talk now about rural health transformation. H.R.1, cut close to $1 trillion on Medicaid, and then, if you recall back to the heady days where this was being discussed and negotiated, there was the stance from Congress. Okay, we'll add back $50 billion for rural health specifically to try and offset some of the cuts. Of course, 50 billion, 1 trillion, those numbers don't quite add up, but it was exciting because of the framing around it. And the framing was specifically about, we're not going to build new hospitals or new care settings. We're not going to necessarily allow you to invest in or just get new EHR licenses, but we are going to ask you to invest in technology to extend care across rural health settings. $50 billion sounds big until you think about, the denominator, 50 states. Say more about what this actually is and what it isn't from your experience.
Yeah, I mean, I think the real positive here is there have been rural health disparities for a very long time. So this is an opportunity to see how can we fundamentally make some progress in rural health. So I think that is a really positive thing. But yeah, to your point, California is getting, $233 million a year. For the record, I probably, as state Medicaid director, couldn't even do a 1% increase on primary care, and it costs that much. I mean, it'd be more than that, right? So you have to understand the dollars here are going to be targeted, but there's also really a good focus on it. So a lot of it's going to workforce. How do you expand your workforce? How are you going to increase your workforce, train your workforce, make sure that you are reducing rural bypass? The number one thing that this has to do is reduce rural bypass. So what that means is essentially people aren't driving really far to urban areas to get their care. They're staying in rural areas to get their care. It's the only way rural providers will remain stable and be able to win the financial pieces. The biggest issue for rural hospitals is they have these standing costs they have to meet state regulations. They can't give them up. So you have to stabilize the bottom line, right? So workforce and how you do that in this, almost all states are looking at. Technology, huge opportunity with technology and data informing different analytics to help them understand where are your biggest financial vulnerabilities, where you should be plugging in workforce, where you should be looking at IT or telehealth to fix your problems, but doing that in a very good analytical way to drive real problems that then, again, help their bottom line, which is really, really important. And then the last one, you're kind of seeing a variety of different delivery system transformations. Hub and spoke, whatever it may be, how are you partnering regionally in rural areas so that each rural hospital doesn't have to solve all of the region's problems, but they're partnering in ways to share resources, data, information, and pieces. Now, what I would say is those are really complicated problems to solve. They are not easy, and so states are going to have to rely on partners to come to the table because this thing, talk about moving fast, is moving fast. The timelines and the threat of if you don't meet the moment, we take away your money will be real. And so states will need partners to do this in a very, very real way. But the potential of really stabilizing or attempting to make some progress and stabilization in rural health is very exciting, to be honest with you, and just a big opportunity.
Yeah.
I agree with everything that Jacey said, and I've been really bullish publicly in a lot of spaces about the importance of this effort and the importance of state health secretaries to really lean in and to try to draft off it. I mean, as the person who governed over a health system that in the preceding decade had seen 11 rural hospitals close, we understand the dynamics here are unsustainable. And yet there's this really hard political thing that we deal with in states where no one is more in love with anything in the world than their local rural hospital. And many of our legacy Hill-Burton rural hospitals in this country are on their way to becoming exclusively SNFs. There is not a lot of sustainable funding. A lot of these communities don't require 60-bed hospitals. The model of care, their average patient bed days is like 10. And yet getting them from what they have to maybe what could be sustainable, something that looked like emergency room only, urgent care, primary care, community healthcare workforce, and a helipad, is a really hard transformation, and it's as much political and local personalities as it is resource. And so my hope is that in a lot of this, and what Jacey outlined beautifully, is that there's an opportunity to create some centers of excellence or some examples of what could be that people can then follow. But make no mistake, this is a down payment if we really want transformation. This is only a start to try to get there, but really good. Just some pragmatic, practical things for everybody in the room to hear, like states haven't even finished their budgets yet. Those are due January 30th, right? So everybody who thinks states have money, they don't got money. So like, stop harassing them if you're trying to get some of that money. Second thing is many states will have to go through a legislative process even to get access to the money after getting it from the feds. And so, add another 90 days there. Many states will go through classic procurement processes to then hand this money out to do subgranting. So add another 90 to 120 days there. And so some of this money may not flow in certain states until like August, at which point I think the federal government will start to look at ways to recoup it and redispatch it. So I think it's going to be a bumpy first year.
They have to spend the first years by, I want to say, September. It has to be obligated at that point.
It has to be obligated
Right.
by July 31st,
Yes.
and then they have until the following year to get money out the
Yes.
door. But just to get to the obligating by that date, for the record, is going to, with government, that's going to be a challenge.
You just heard the timeline stacking up, right? That is really, really challenging. So maybe take a minute to back off the inboxes of the state leaders who are every state has a different way of doing this, Office of Rural Health Transformation, or maybe out of the governor's office. It just depends, right? We can tell you where those folks are, but maybe give them a moment, but be ready to jump in with exactly what they need, I guess, by mid-year.
I mean, I think that's right, Lisa. And this is why I think for your positioning in the room, and to echo what Jacey said earlier, like this is where states are going to be looking for partners ready to act.
Yes.
Right? Partners with
Shovel-ready projects.
Shovel-ready projects, partners with already deep relationships in rural communities, strategies that are proven, the ability, they're not looking to partner with someone who's going to start new and fresh and bespoke. Like they're going to look to how do we partner with folks that we can double down on pre-existing efforts. And this is where public-private partnerships, to overuse a phrase, are going to really shine. The opportunity to double down on things where you also have skin in the game.
Yeah, that's right. And I will just say as well, as someone, I'm Californian, grew up in a very, very rural community. What you were saying before is absolutely real. I'm from Mendocino County, not in one of the towns, way outside in the country. It takes about 3+ hours to drive to San Francisco, whereas where you're gonna find all of the specialists, you will find none of them in the closest town to where I grew up. This is very real for California, and for other large states that are getting a much smaller piece of this pie and have tons and tons of complicated delivery systems to explore and figure out what we can do. We are working, folks probably know, with the Population Health Management Initiative, PHMI, with Kaiser Permanente in the state, Population Health Learning Center. There are ways to get some of these tools out to people, to FQHCs and health centers who are in those regions. But like you said, Kody, there's a lot of work to do that transformation and say, okay, we're not going to be everything. We're going to be what we need right now in this community. What does that look like long-term sustainably? That's really, really challenging. So anything else on what is going to separate the organizations who are going to do well here, and what's going to separate the organizations and maybe even the states who won't do well here?
Yeah, I mean, I think one thing that states have to understand is if rural health could have solved this with just a little bit of funds, we wouldn't be here. And what I mean by that is they're doing the best to kind of keep things functioning. An AC goes down, it can completely tank their bottom line because of how fragile they are. So if a state thinks by just giving money, a subrecipient money, is going to actually change the way they operate, and the previous panel highlighted this, I think is an important piece, or that AI, applying an AI model in a rural hospital is going to change everything. It's not. You actually have to change the workflows in that hospital or facility, whether it's a birthing center, whether it's a hospital, whether it's an FQHC. You have to actually provide either the dollars or the consulting resources to go in and help the hospitals or the rural facilities change their workflow, train their staff. It can't be, and this is, and states are all approaching this differently. Some are just going to give the funds and hope and wish it's going to change, and some are funding technical assistance centers and large entities to go in and actually help the facilities transform the way they operate, so that there is more sustainability. So I think that will really separate, is if you're just giving money, you won't have a lot to show for it at the end. And that may be some people's objectives, just to be honest with you. States are going to approach this all very differently. But if you actually want the change, you need to be able to give them the tangible technical assistance, resources, and tools to do that well. I also think this is the moment for population health to shine. Everybody uses rural health as like one of the shining things. Longitudinal data is so important in rural health because they get their care from so many different people because of the nature nature of what that means, where you can't get it always locally, you get as much as you can locally, and you're going to different systems. And so really thinking about how that works in this space and how they're thinking about that to lift up primary care in rural health will be really, really important and a game changer, I think, hopefully, if the investments are done right. But again, if you rely on the rural health facility to implement the EMR or to implement the upgrade or to do those things, it's not going to work. You actually have to bring in the resources to do it for them and to help them do it right because their bandwidth is low, their workforce is low, and they have churn on staffing that is way higher than other facilities.
Yeah, absolutely.
I think broadening to the entire environment of H.R.1 implementation in the year, my message is partner, don't popcorn. Partner, don't popcorn. Write it down. Nobody's writing.
Partner, don't popcorn.
And my point in saying that is that, this is the time when, we're going to see a lot of changes happening on who's covered, how coverage works. We're going to see things moving quickly, fast. There's going to be a whole lot of noise. And so I think you kind of zoom out and look at how these things link together for trend lines and what states are doing. It's an important time to think about how to partner across various organizations, whether it's in the verge of population health efforts. It's an important time to partner across different programs. So, we've talked about Rural Health Transformation Program, but there's also CMMI's access model that's rolling out that people are, of course, watching closely. What are the through lines in your strategy that are going to check multiple boxes? How are you aligned with the Rural Health Transformation Program, opportunities in CMMI, some of the data initiatives that are coming out of CMS? How are you checking one box with multiple things and not trying to scattering across? And so I think the paths to success this year are, partnering with the state on these efforts, moving across multiple things, but try to really stay focused and don't get a little too distracted by the noise. If anybody didn't think there was a lot of noise in this policy environment, then you've been keeping the news off.
Yeah, so actually you're leading us really into our next panel where we are going to go into more detail on the access model and how it fits into the rest of this world. But before we end, we hope to have time for questions. We really don't, but I will tell you, each of these two individuals, does a lot of advising in the space. They're going to be around here for a minute. Kody in particular loves questions. I assume Jacey also loves questions. So please do find them at the break if you can. And they have a wealth of experience working with two really dynamic states. So definitely please hit them up and have a conversation about some of the things we talked about today. Okay, that's all we have time for. Thank you so much, Kody. Thank you so much, Jacey. Appreciate it.